Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning. I would like to thank everyone to be here. My dear lecturers, because I don't see my professors here. And there's also postgraduate students and undergraduate students. It is an honor to be here and it is a great pleasure for me to become a moderator of this clinical pathological conference. So departments of Otorinolaringology will host this CPC and the topic today is dealing with Droopy phase and Vertigo post-trauma, debilitating but treatable. I would like also to take this opportunity to welcome the postgraduates and undergraduate to ask questions during this CPC. The reason why I want everyone to be focused and participates actively because sometimes you are not trained your brain to ask questions and that's why we just absorb whatever lecturer that giving you information. But you need to train your brain in order to follow the thought and ask questions. Why is it important for us to know about the traumatic facial nerve palsy is because you can give an opportunity for the patient to have a good muscle expressions. Okay, so the three speakers in this CPC, which include Dr. Wan Nabila Wan Mansor, our specialist in departments of Otorinolaringology, and I would like also to thank Dr. Muhammad Aminuddin Ashari, who is a lecturer and radiologist from from departments of Radiology, and my registrar is Dr. Pravina Anak Perempuan Pospanathan. So without further ado, I would like to invite the first speaker, who is Dr. Pravina, to be here to deliver the speech. Thank you.
Thank you, Prof. Asma. A very good morning to all esteemed professors, respected lecturers, and dear colleagues. I'm Dr. Pravina Pospanathan, a postgraduate trainee from Department of Otorinolaringology. It is my privilege to present today's case for CPC. The case presentation, a 53-year-old male was involved in a road traffic accident in July 2024. He was riding a motorbike and skidded after he hit a pothole. He developed loss of consciousness, unsure of duration, and retrograde amnesia. Upon arrival at emergency department, he developed 2 episodes of vomiting and right ear bleeding, which resolved spontaneously. He noticed that he has right reduced hearing with intermittent non-pulsatile tinnitus. He has no facial weakness. He was admitted to the ward for observation. He only noticed right facial weakness at day 4 post-trauma. He was unable to close his right eye with maximal effort associated with dryness of the eye. He had drooling while drinking. He complained of spinning sensation lasted a few seconds, triggered by head positioning. The symptoms occur upon waking up from lying position. However, no nausea or vomiting. Right hearing loss and tinnitus were present. Otherwise, he has no other ear symptoms such as ear discharge, othalgia, and ear fullness. He has no rhinitis symptoms, epistaxis, or nasal block. He has no food or drug allergy, family history of hypertension. He has no medical illness or past surgical history. His social history, he lives at Bandar Tun Razak, married, blessed with 4 children. He worked as a retail assistant. He was an ex-smoker and does not consume alcohol. Next, we will go on to the physical examination. From the eye, with physical examination of the facial nerve, there is no the eye examination, there was no spontaneous nystagmus. The right eye, there was subconjunctival hemorrhage. The facial examination, there was multiple laceration and abrasion wounds with scabs. The right facial nerve palsy was a House-Brackman grade 4, Bell's phenomenon present with intact corneal sensation. As you can see, the images image 1, 2, and 3, this is the cranial nerve examination for cranial nerve 7. So from the first photo, we can see that the patient has loss of forehead crest that is testing the temporal part of the temporal branch of the facial nerve. And the second photo is to test the zygomatic and the marginal mandibular. And the buccal branch, usually we ask the patient to puff their cheeks so that they can, and we have to see whether they can sustain the pressure of the puffiness. So the facial nerve examination, the motion of the head was none, the eye was an incomplete closure, the mouth has an asymmetry with maximal effort. So the House Brakeman for this patient is grade 4, which is a moderate severe dysfunction. From the ear examination, the pinna was normal, no overlying skin changes, no tenderness upon pulling the pinna or over the Simba concha, tragus and mastoid region. The otoendoscopic examination, this is a video. As you can see, the right ear, there's a displacement of the anterior wall of the bony EAC with blood stain, and the tympanic membrane is actually intact, but it's a bit bluish discoloration, which shows that it has a hemotympanum. From the left ear, you can see the ear canal is actually normal, the TM is intact, but there is a tympanosclerotic patch. So fistula test for this patient is negative. So fistula test is a test where we put a pressure on the external auditory canal, so it will have a triggered nystagmus or a vertigo for the patient. Means there is if it is positive, it is a parallel fistula, but in this patient it was negative. The tuning fork test for this patient, the Rini's, the right side was negative, the left side was positive, the Weber was lateralizing to the right. Thus, the conclusion for the Rini's test was a right conductive hearing loss. The free field voice test, the right patient was able to repeat normal conversation at 2 feet, which indicates a mild to moderate hearing loss. The left patient was able to repeat whisper at 2 feet, which indicates a normal to mild hearing loss. So from the balance assessment, from the Romberg's test, patient was swaying to the left, and from the Dixon pike, there was a rotatory upbeating nystagmus bilaterally. As you can see in this video, there's a upbeating rotatory upbeating nystagmus. And thus, on the supine roll, the patient have an upper geotrophic nystagmus, more intense to the left side compared to the right side. So the right side is affected. So usually the nystagmus is more intense on the opposite side than the pathological side. So the conclusion is a multi-canal bilateral posterior canal and right lateral canal traumatic benign paroxysmal positional vertigo BPPV. We proceeded with Apiadi and Kasani hybrid maneuvers. To these canal lead repositioning maneuvers. So from nasal examination, the external nose and cold spatula test was unremarkable. Anterior rhinoscopy, there was no septal hematoma. Rigid nasoendoscopy was normal except for the bilateral inferior turbinates was hypertrophy. Intraoral examination was unremarkable and other cranial nerve examinations were normal. Hearing assessment, pure tone audiometry, right side he had a mild conductive hearing loss at low frequency and moderate to severe mixed hearing loss at mid and high frequency. His left side was a normal hearing. The tympanometry for this patient, the right side was type B, indicates fluid in the middle ear or a hemotympanum, as we saw the video on the otoendoscopy. And the left side is tympanometry type AS, indicates a low compliance and a stiff middle ear system in view of the tympanosclerotic patch which we saw earlier. So the next test that we did for the facial nerve was the electroneurography test, that is called a ENOG-G, and the nerve is also known as a nerve conductive study. So from the nerve conductive study, we have noted that the patient has right facial nerve 88% axonal degeneration. So, in summary, a 53-year-old male who was involved in a road traffic accident sustained loss of consciousness and right reduced hearing with tinnitus post-trauma. He developed right facial nerve palsy at day 4 post-trauma. He complained of spinning sensation triggered by change in body position. On examination, he has right facial nerve palsy, House-Brakeman grade 4. Balance assessment revealed positive disc sulfide and supine rule maneuvers. Hearing assessment showed right mild conductive hearing loss at low frequency and moderate to severe mixed hearing loss at mid and high frequency. He has right facial nerve axonal degeneration of 88% based on electroneurography. Well, my provisional diagnosis for this patient is delayed traumatic right facial nerve palsy with ossicular discontinuity and traumatic BPPV with cerebral concussion. Our differential diagnosis was delayed traumatic right facial nerve palsy with perilimb fistula and cerebral concussion.
Hello? Thank you, Asma, for the question. So, bell phenomenon is usually happen to the facial palsy that the patient have a protective reflex in terms of the upper limb of the eyeball and then the anesthesia of the eyes. So, basically, if this patient have this phenomenon, the patient is protected from the corneal ulcer or exposure keratitis.
Okay, so uprolling of the eyeball, uprolling, so that there is no exposure to the cornea to prevent exposure keratitis. So now, Dr. Sasi, so why do you think that the PTA shows the finding just now? Can you explain why the patient has the PTA like this?
This is a PTA of this patient. On the right side, it shows conductive hearing loss on the right ear with an airborne gap of at least 30 decibel. There's two factors here. One is a middle ear effusion, which is he has a hemotympanum. That's number one. The other one is possibility of ossicular chain discontinuity as well.
Ossicular discontinuity. Why the patient has sensory neural?
Could have been a traumatic injury to the cochlea itself. Could be a temporal bone fracture.
Concussion. So cochlear concussion give rise to
the sensory neural
reduce
hearing loss.
in terms of air conduction threshold. Okay, so you all understand why there is a PTA. Supposed to be everyone have a normal PTA, right? Okay, so now proceed with the discussion. Thank you.
Delayed traumatic right facial nerve palsy with ossicular discontinuity and traumatic BPPV with cerebral concussion is our differential diagnosis. So the points for conductive hearing loss with large airborne gap of 30 decibel at low frequency from the pure tone audiometry, persistent conductive hearing loss after 6 weeks, sensory neural component likely due to brain concussion, vertigo is episodic, positional and lasted for few seconds. Proven by disc sulfide and supine rule maneuvers. So the point against is the traumatic BPPV is rare, less than 20%, often overlap with brain concussion. So my second differential diagnosis will be delayed traumatic facial nerve palsy with perilimb fistula and cerebral concussion. So the points for why we suspected to be a perilimb fistula because of the presence of the hearing loss, vertigo, and tinnitus. It can be due to temporal bone fracture as well. But the points against will be the absence of sudden fluctuating sensory neural hearing loss, the absence of Tullio phenomenon, absence of other symptoms such as autophony and oral fullness, and negative fistula tests, and positive disc sulfide or supine rule maneuvers. Thus, the perilimb fistula can be ruled out. So,
Dr. Pravina,
yes.
the students not sure what is a perilymphatic fistula. So anyone that you want to ask from your friends, what is a perilymphatic fistula? The student don't know. They don't know. They only know the malleus, incus, and stapes. They don't know perilymphatic fistula. Okay, anyone volunteer before Pravina will say your name?
Okay, I will ask Isaac, my fellow colleague, to answer this question.
Thank you, Dr. Pravina. So, perilimb fistula is an abnormal connection because normally in the labyrinthine, in the cochlea, there is a separation between endolimb and perilimb. And when you have a traumatic or it can be acquired, you have an abnormal connection causing the mixing of these fluids. So it will cause, that's what explained by perilimb fistula.
Okay, so I will elaborate about the perilymphatic fistula. Perilimb fistula is a condition whereby there is an abnormal communication between the middle ear and the inner ear. Abnormal communication. Supposed to be the oval window and the round window covered. The round window covered by the round window membrane. The oval window is covered by the stapes foot plate. So when there is a trauma hits towards the head, there will be a possibility of fracture of the stapes. And when there is a fracture of the stapes, there will be a leak between the perilimb from the inner ear towards the
Middle ear.
middle ear. So there will be a communication. Understand? Okay. Okay, continue.
Thank you, Dr. Isaac. Thank you, Prof. Now I would like to give the stage to Dr. Aminuddin Ashari for the next topic, the radiological part of the conference. Thank you.
Okay, thank you, Dr. Pravina. Okay, so we actually have one set of CT brain and cervical, which was performed on 24th of July 2024. Just as disclaimer, ideally in these cases, we'd like to perform a high resolution CT temporal where the thickness is about 0.5, but the slices that we have are 0.8 to 1 millimeters. Okay, so we just go to the CT brain soft tissue window first. As you can appreciate, there are multiple extraaxial hyperdensities here at the anterior temporal regions in keeping with hemorrhages. So these are extraaxial, most likely subdural in nature. And also on the left temporal going towards the frontal, there is also extension of this hemorrhage, as you can see on the arrows. Okay, the patient also has a pneumocranium at the subdural space. And also there is hemosinus at the sphenoid and also the ethmoid sinuses. At the orbits, there are also a bit of periorbital hematomas. Okay, the patient also has several fractures. Firstly is the lateral pterygoid on the right side. As you can see here, that's the fracture. And also the patient had a fracture of the planum sphenoidale, okay, as well as the lateral wall of the right sphenoid sinus. So now we go to the area of interest, which is the right temporal bone, where the patient had a comminuted fracture. It involves the squamous part and also the zygomatic arch. Okay, this is the VRT, the volume rendering technique of the skull, showing the fracture on the right side, and this is the normal left side. Okay, so now it's the 2D view in axial plane. So this is the fracture. As you can see here, this is cortical discontinuity of the right temporal bone. And then the fracture, as you can see just now on the surface anatomy, this is how it looks like on 2D. Okay, there is this is, again the fracture. So there's two sides of the fracture here, and this fracture line here, the trajectory is quite close towards the tympanic part of the facial nerve. Okay. At the EAC, correlating with the findings earlier on clinically, you can see that there is a bone fragments noted at the anterior EAC causing slight narrowing. So these are bone fragments from the fracture. And this is the normal EAC, what it should look like. Okay, and this is the sagittal view. So looking from the side, you can see that on the left side, you can see nicely the EAC. But on the right side, you can see this is the fracture line and the narrowing just now that we saw on the scope findings. And this is the coronal view. sorry, the image is a bit grainy. So this is the fracture line on coronal view. Okay. On the left side, you can see that this is the incudomalleolar complex. So it gives the normal ice cream shape cone appearance. So this is the head of the malleus and also the incus. But on the right side, so this one, this is normal. On the right side, there is slight widening of the incudomalleolar joint. So this can indicate subluxation of this ossicle. And then this is the long process of the. Okay, as you can see, there is a discontinuity here, which is suspicious of a fracture as well. Okay, now we go to the inner ear. So the fracture line, I said just now, the trajectory is quite close to the tympanic part of the facial nerve. Okay, this is the left side. So you have the labyrinthine, geniculate ganglion, and also the tympanic part. So in this, the right side, the fracture line goes close to this. And in the coronal view, so this is the normal left side. You can see there's a bony covering here. But on the right side, there's hemotympanum, and we don't really see the bony covering of the tympanic part of the facial nerve, facial canal. So this is suspicious of dehiscence. Another subtle finding is the angle of the incudostapedial joint. So this is the normal side on the left. It's supposed to be about 90 degrees, while on the right, the angle is slightly reduced. So I think that will be discussed further in the op findings later. So the angle here is slightly abnormal. And there's also the fracture line goes close to the second genu. This is in the axial plane. And in the sagittal plane, you can appreciate there's a subtle fracture line going on here, just at the second genu. And this is normal left mastoid part and also the second genu. Okay, so in conclusion, there are multiple extraaxial hemorrhages at the left frontal and bilateral temporal regions. There's a comminuted right temporal bone fracture with hemotympanum. And also there's a suspicion of right tympanic segment facial canal dehiscence and a comminuted bony EAC fracture on the right side. And also there's a suspicion of a right incudomalleolar joint subluxation and long process of incus fracture. So as regards to the the perilim fistula, we don't really see any pneumolabyrinth, which is air within the cochlea that would suggest a perilim fistula. And also the multiple fractures I mentioned earlier. And the patient also had a cervical CT done, but that was negative. Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Dr. Aminuddin, for a very concise explanation regarding the radiological imaging. So my name is Dr. Wan Nabila Wan Mansor. I am the lecturer and also specialist from ENT department. So I will discuss further regarding the provisional diagnosis and also the management for this case. So the provisional diagnosis is delayed traumatic right facial nerve palsy with ossicular discontinuity and traumatic BPPV with cerebral concussion. So the management in this case, the forefront strategy in this case is to give conservative treatment first, which includes steroid therapy and physiotherapy. So in this case, we gave the patient IV dexamethasone 8 mg TDS for 3 days, then prednisolone 60 mg per day, which is the maximum dose for 2 weeks. And when the facial nerve function still remains the same in House Bregman grade 4, patient was counseled and subjected for surgery, which is facial nerve decompression with or without ossiculoplasty. So patient has underwent right facial nerve decompression via transmastoid approach on 29 of August 2024, which is 30 days after the onset of facial nerve palsy. So the findings that we can see that there were fracture lines at the zygomatic root, and the second genu and posterior wall of the EAC. And if I show you the video, so basically, okay, I will orientate you. So this is the superior part, which is the tegmen. This is the posterior part, and this is the anterior part. And this is the posterior wall of the EAC. And this yellow, I think everybody knows what it is, right? This is the lateral semicircular canal. So this is the antrum. This part is the antrum, the epitympanum. So we widen the epitympanum. So in this case, we already performed extended posterior tympanotomy, in which we remove the superior buttress at this part. So we will expose the tympanic segment and the second genu, and going inferiorly, it will be the mastoid segment. So this is the tympanic segment. So the tympanic segment looks very edematous, and it is dehiscent, okay, at the tympanic segment, which can be found in 50% of the population. There was fibrotic tissue with adhesions at the epitympanum, mesotympanum, and surrounding the incus. So you can see here, you should find incus over here, right? So the incus was dislocated from the incudostapedial joint and was attached to the tympanic membrane, and there was adhesion between the ossicles. So when we palpate the ossicles, it looks like the ossicular change was mobile. So we did not proceed with the ossiculoplasty. So you must be wondering, what is ossiculoplasty? It is a surgical procedure to restore the hearing mechanism from tympanic membrane to the oval window, okay, by establishing the ossicular chain. And then there are these are the prostheses that can be used in ossiculoplasty. And this is partial ossicular reconstruction prosthesis, which is from the tympanic membrane to the stapes superstructure, and total ossicular reconstruction prosthesis, which is from the tympanic membrane to the stapes footplate. And upon follow-up at 3 weeks, the patient has a well-healed right post-auricular scar, the right fascial palsy from grade 4 to grade 3. Patient able to close his eye with maximal effort, mouth is still slightly weak. Okay, so you can see from the video, the hearing has improved. You can see here the patient has a mild to severe mixed hearing loss with a smaller airborne gap. And at 2 months follow-up, patients have a right fascial palsy house fragment grade 3. However, patient complains of episodic vertigo associated with body positional, which lasted a few seconds. But he experienced giddiness throughout the day. And this has hallpipe proven that there was a right rotatory upbeating, nystagmus. Then we proceed with the Epley's maneuver. So you can see here, there's a rotatory upbeating nystagmus. Just lasted a few seconds. And since it's peripheral, so it has fatigability. And you're probably wondering, why does patient have giddiness? Okay, you can explain episodic vertigo by patient have BPPV, this patient have the episodic vertigo. But what about giddiness? What could explain that? And this when you will encounter many vestibular diagnostic tools. And in this case, we subjected the patient for VHIT. Okay, when you are not sure with the diagnosis, there are many tools that can be performed. Okay, in this case, we want to assess the semicircular canal. Okay, so in this case, patient have normal gain in all canal, which means patient have normal semicircular canal. All right, so based on American Institute of Balance, 1 out of 6 patients presented with vertigo. Okay, they have more than one diagnosis. Okay, so when patients have symptoms which are not typical of BPPV, we should investigate further. And post-operative follow-up at 6 months, patients have no more vertigo episode. And the fascial palsy is now grade 2. If you can see at rest, it's almost grade 1. Okay, patient have complete eye closure with minimal effort, slight mild asymmetrical movement, but it looks symmetrical. And this is the autoendoscopic findings. This is the right side, the anterior wall displacement. So the TM is intact. On the left side, TM is intact with tympanosclerosis. And the PTA, pure-tone audiometry, shows that patients have a normal hearing at high and mid frequency, but mild to moderate hearing loss at high frequency. The left ear is normal. So now we come to the management of traumatic fascial palsy with ossicular discontinuity and traumatic BPPV. So first, what is our temporal bone? Okay, so temporal bone comes in pairs, okay, in humans, and it can be divided into parts, which is squamous part, petrous part, tympanic part, mastoid, and also styloid process. Okay. And this is the facial nerve course in the temporal bone, from the internal acoustic meatus, and then from the fundus to the geniculate ganglion. This is the labyrinthine segment, which is the shortest segment and the segment which is prone to injury. And you have the geniculate ganglion here, and then the tympanic segment, the second genu, the mastoid segment, and it comes out through the stylomastoid foramen, and it becomes the extratemporal branches. And this is the parietic plexus. So temporal bone fractures was first classified into longitudinal fractures, transverse fracture, and mixed fracture by Ulrich in 1926. So this is the longitudinal fractures that runs along the axis of the petrous bone, and this is crosses the petrous bone. This is known as the transverse fracture. So comparison between both fracture, longitudinal is the most common fracture, okay? And what are the symptoms associated with longitudinal fracture? Bleeding from the ear, cerebrospinal fluid, CSF rhinorrhea can occur, and structures injured in longitudinal fracture are tegmen, ossicles, tympanic membrane, but transverse, because it involves the labyrinth, so there will be sensory neural hearing loss. Okay, but longitudinal fracture mostly are conductive hearing loss. And facial nerve paralysis are most common in transverse fracture, about 50%. And there's also a new classification by Kelly and Tammy, which can be divided into aortic capsule sparing fracture and aortic capsule disrupting fracture. Okay, aortic capsule sparing fracture is the most common, about 95%, and it spares the aortic capsules. And for aortic capsule sparing fractures, mostly involve the ossicular change, therefore leads to conductive hearing loss. And facial nerve involvement is less common as comparison to aortic capsule disrupting fracture. So generally, the management for traumatic facial nerve palsy, it can be divided into conservative or surgery. When you talk about conservative, we are talking about steroid course and physiotherapy. It doesn't matter, you want to give dexamethasone, methylprednisolone, or prednisolone. And surgery, it involves a facial nerve decompression with or without ossiculoplasty. So traumatic facial nerve palsy can occur about 5 to 10% in temporal bone fracture. The common cause of temporal bone fractures are traffic road injuries, falling from height, assault, and gunshot. And it can be divided into immediate, which is within 24 hours, or delayed, more than 24 hours, depending on the onset which occurs after the trauma. So what are the investigations to guide your management? Okay, so you must have a high-resolution computed tomography CT scan, as Dr. Amin have mentioned before. Electrophysiological tests reported via ENOG, which is electroneurography, performed 3 to 14 days after the injury, or electromyography, EMG, performed 2 weeks after the injury. You can perform topodiagnostic tests to identify the site of the injury, and audiological assessment, in which it's important to decide the approach of the surgery.
Miss Wan, maybe Miss Wan can ask one of the postgraduate student why that you only can do the ENOG after 3 days.
Okay, I would like to ask Dr. Jean, why do we perform ENOG after 3 days?
Hi, I think ENOG is only done after 3 days because of the appearance of Wallerian degeneration that starts after 3 days.
Okay, because of the Wallerian degenerations. Okay.
They will ask what is Wallerian degeneration?
Wallerian degeneration is degeneration of the axons of the distal stump of the injury at the distal stump. Is a part of the process of regeneration.
Okay, part of the healing process of the nerve. Okay, continue.
Okay, so what we practice in our center, the indications of surgeries are immediate onset and complete paralysis with House Bergman grade 5 or 6, electronography ENOG more than 90% degeneration, when there is presence of bony spicule impinging on the nerve or fracture line crosses the facial canal, when there is a progressive deterioration of facial nerve palsy or worsening of the ENOG, and there's no improvement after steroid therapy. So these indications does not stand alone. So you must have it's a combinations of one or two. Okay.
Okay, I will ask Dr. Radha. There are one more factor that Ms. Wan purposely not putting here. But there's one factor. What are the indication for surgery? If let's say you say that despite of this one, you still don't want to do a surgery. Can you give me an example? Yeah.
Not for surgery.
Not for surgery. But there is a complete facial nerve palsy.
Could be anesthetic risk, patient has eye risk or
Okay,
comorbidities.
yes, good. One more.
The surgery, the incidence of trauma has been more than 2 years from.
Okay, it's too long. Okay, there is not much. Okay, it's already 1 year. Maybe you don't want to go. One more factor is if let's say the facial nerve injury is happened not inside the either labyrinthine segment or geniculate ganglion, it's beyond that. At the it is more proximal. So then you don't want to do any decompression, right? Okay.
If I may ask on that,
Okay.
in case it is a proximal injury,
Mhm.
is there a role where we can do other approach instead of a transmastoid?
Okay, so another approach that you talk about in terms of when there is injury of the facial nerve at the IAM, for example, right? In the IAM. So if let's say in the IAM, so if you have a facilities of very good surgeon, good facilities, you can do a decompressions at the medial cranial fossa. But the problem is in terms of at that particular point, there will be a problem in terms of identifications and the risk of major surgery. Okay, and it must go from the medial cranial fossa. You can go from the translab, but it's too difficult because too long. Okay. Maybe this one is not for undergraduate, it's more for the postgraduate student.
Right, thank you very much for Asma. Okay, so I have highlighted what we practice in our center, but there's also recommendations from literature, which is also similar with what we practice right now. So decompression surgery is recommended for patients with immediate onset facial nerve palsy with complete degeneration and should be performed within 2 months to offer better prognosis. And patients with immediate complete paralysis with non-improving facial function on 2 weeks of medical therapy. So in this case, they subjected the patient to 2 weeks of medical therapy for those with the immediate complete paralysis and those with the ENOG showing more than 90% degeneration and EMG showing fibrillation potentials were considered surgical candidates. And for conservative, they subjected those with a delayed or immediate onset with ENOG less than 90%. Okay. And patients with more than 95% degeneration with denervations or fibrillations, potential EMG, to be considered the most ideal candidate for early decompressions. Therefore, electrophysiological tests are very important. Okay, it had been estimated up to 50% of temporal bone fracture result in ossicular injury. And those with a simultaneous ossicular chain fracture or dislocation, ossiculoplasty can be performed in the same setting of facial nerve decompression, like in our case. So factors that determine the approach of facial nerve decompression, of course, the site of injury, geniculate ganglion, tympanic segment, and lateral labyrinthine segments are most commonly affected in the case of post-traumatic facial nerve palsy. This I will discuss further on the next slide. And the hearing level. So non-serviceable hearing with site of injury at the labyrinthine or geniculate ganglion are candidates for translabyrinthine approach. And also depends on the expertise as well. And this is the summary of the facial nerve decompression approaches. So in this case, we do transmastoid approach. It is most widely used approach, good access to the mastoid and most of the tympanic segment, but limited access to the geniculate ganglion and antral portions of the tympanic segment. And we talk about medial cranial fossa. It is indicated in patients with serviceable hearing. Affected area spans from geniculate ganglion to labyrinthine segment. But again, it's lengthy, high mobility, and when combined with transmastoid approach. Translabyrinthine indicated when hearing is non-serviceable. So you're probably wondering what is serviceable and non-serviceable hearing. So anyone want to answer the question? How about Dr. Sasitaran? Again.
Non-serviceable hearing is hearing loss, which is, of course, profound, or at least more than 50 decibel. And it's not audible, and with speech discrimination.
Okay, serviceable hearing means that the hearing level is less than 50 dBHL, less than 50. And the speech discrimination score is more than 50. Okay, non-serviceable is the vice versa. So non-serviceable means that the hearing threshold is more than 50 dBHL, hearing level, and the speech discrimination score is less than 50%. Okay, it's not moderate, severe, profound, no, it must be, okay? Okay, continue.
All right, thank you, Prof. So another approach is transcanal endoscopic approach, which requires steep learning curve, less invasive direct approach and least mobility, and it can be indicated in decompression of the geniculate ganglion tympanic segment. So our case, actually, we can perform transcanal endoscopic. However, if you can see the ear canal, the view is limited because of the anterior displacements of the ear canal. However, in transcanal endoscopic, must counsel the patient regarding these articulations of the incudo-malleolar joint and incudo-stapedial joint because it requires removal of the incus for access. Thus, patients require ossiculoplasty. Now we come to vertigo post-trauma. Okay, so in this case, patient was diagnosed with BPPV, traumatic BPPV. So it is a condition where otocornea dislodged from the utricle traveling along the semicircular canals. So the likely theories by Shupneck and Pons and McClure divide the mechanism into cupulolithiasis and canal lithiasis. Idiopathic is the most common cause, but in trauma setting, BPPV has typically been reported to be the most common cause of post-traumatic dizziness. Secondary BPPV or traumatic BPPV is due to head trauma, which can occur as early as a few days or 3 months. It's often associated with poor prognostic features because of bilateral disease and higher rate of recurrence. So in a prospective observational clinical study, among 128 patients with mild and moderate traumatic brain injury, 22 patients were diagnosed with BPPV, 17%. A study by Liu revealed that 55% with traumatic BPPV involved 2 or more semicircular canals, which is true because most traumatic BPPV have multi-canal involvement. So traumatic BPPV, the main features are usually bilateral, multi-canal, and usually most likely due to otocornea detached by trauma with presence of microscopic hemorrhage or tissue shearing. In traumatic BPPV, a single maneuver may not be sufficed due to bilateral and persistent nature. But we must bear in mind, like in this case, why we have to do other diagnostic vestibular test tools is because patients have other symptoms that is not typical. So we must bear in mind other types of causes of dizziness in head injury can be unilateral vestibular loss as well. So this is the Dix-Halpite maneuver. Okay, this is the maneuver to diagnose posterior canal BPPV and anterior canal BPPV. So the patient will turn to the right side or the left side of 45 degrees and then push the patient down with the head extended at 20 to 30 degrees and watch for the presence of nystagmus. So in posterior BPPV, we are expected to have rotatory upbeating nystagmus. And Epley maneuver is the canalist repositioning maneuver for posterior canal BPPV. So Epley maneuver is performed, it's just like a continuation of the Dix-Halpite. Patient turn 45 degree, can either put pillow underneath the shoulder and watch for nystagmus, okay? And each steps should be performed in within like 30 seconds to 1 minute, okay? So the outcomes of facial decompression. So what we found out, and based on literature, 18 patients who underwent surgical decompression within 2 weeks after injury achieved perfect recovery, which is house Batman grade 1 of 72.2%. If you compare those who underwent surgery more than 2 months, the rate of recovery was 16%. Thus, this proves that early surgical intervention can significantly improve the prognosis. So in this case, patients show a fast recovery after fascial decompression, likely attributed to early surgical intervention. In delayed traumatic facial nerve palsy, there is a dearth of research regarding the conservative management and facial nerve decompression. There is no comparison between both groups. So another study reported that 7 patients with delayed facial nerve palsy conservatively treated with methylprednisolone, and all of them achieved a normal facial nerve function. So conservative treatment can yield good outcome. However, decision for surgery versus conservative treatment should be individualized and follow the criteria. So this is the proposed algorithm by Savvy in 2017, which the same with what we practice in our center. So you have a temporal bone trauma, history and physical examination. When is the paralysis occurs? How's the onset? Is it delay or is it immediate? Okay, if it delay onset, do HRCT, audiogram, and patient may be subjected to non-surgical treatment. So if it immediate onset paralysis, incomplete or complete. Complete, do HRCT temporal, ENOG 3 to 7 days, more than 90% degeneration, plan for surgical decompression. But you must see the audiogram. Is it serviceable or non-serviceable hearing? Non-serviceable hearing can consider translabyrinthine approach. Serviceable hearing, you must see the injury. Is it proximal to geniculate ganglion? You can do middle cranial fossa. Distal to the geniculate ganglion. It's either transmuscular or translabyrinthine. Okay. So the take-home message, this is the final slide. The management should be individualized. Patients should be referred as early as possible to a tertiary hospital. There are clear criteria for surgical intervention, okay, which does not stand alone, okay? So the first criteria is immediate onset and complete paralysis of house Batman grade 5 or 6, fracture line identified involving the fascial canal, ENOG more than 90% degeneration, presence of bony spicule impinging on the nerve, and progressive deterioration of fascial nerve palsy or worsening ENOG, and there's no improvement after conservative treatment. Counseling regarding hearing rehabilitation should be discussed simultaneously with the surgical counseling. The options should be laid out, either hearing aid or conservative or osteoplasty. Early surgical intervention confers better prognosis regardless whether immediate or delayed fascial nerve palsy. It can be as early as possible. And last but not least, the presence of vertigo should not be dismissed as cerebral concussion and should be investigated thoroughly. Thank you very much for your attention.
After listening to very comprehensive discussions on the traumatic facial nerve palsy, I'm sure that you all have a burning question. I would like to invite anyone who has a question. Anyone? Okay, if let's say no question, I will ask Dr. Tilaga. Tilaga, what will decide whether you want to do the same setting of facial nerve decompression and osteoplasty, or you will do a different setting? You do decompression first, then only you do osteoplasty.
It depends on the hearing level of the patient and also how severe is the ossicular discontinuity, the air bone gap, and also if during the surgery, if there's a lot of edema, bleeding, and fibrosis, that will make the further surgery like osteoplasty more difficult. So we can actually delay it. Doesn't mean we have to do it in the same setting. We can plan it later. And also we need to discuss with the patient that osteoplasty might be a bit more expensive. That patient has to, another secondary issue may be the financial part also.
Good. So good answer. So in other words, you all need to know if let's say there is a abnormal anatomy whereby you can't make sure what are the area that you want to do osteoplasty, that you want to connect between the restorations of the middle ear continuity, then you should wait, do as a second stage, provided that the hearing is not improved after the first surgery. Okay, so in other words, one, the factor is intraoperative finding. Number two, in terms of the gap. Okay, if let's say the gap is very minimum, okay, and you don't think you should go for the POP or TOP because the airborne gap is maybe 30 or 25. Of course, more than 40, you think, sure, there is a ossicular discontinuity. Then at that particular point, you can mold or capture or sculpture the incus, and then you connect and you put a tissue glue. So you use the own ossicles, not the prosthesis. Okay, number three, what is number three? Beside the cost, beside the expertise. If let's say there is a central perforation, you want to do ossiculoplasty, you can't do ossiculoplasty because you will expose the prosthesis to the environment, to the external ear. So it become an infection. So you need to make sure that tympanic membrane is intact. Okay? Maybe any other question? From our student from Gaza, we all welcome you to join the CPC and we are welcoming you to the ENT departments later. Okay, I think without further question, I would like to ask everyone to give applause of appreciation to the presenter. Okay, Assalamualaikum warahmatullahi taala wabarakatuh.